AfroPHC website. That's afrophc.org. There's information specifically about the organization, their vision and mission, their vision and mission, many more resources, including detailed bios of all of the panelists. So we won't go into a lot of detail. I want to use the most of the time for the panelists to speak, but please do have a look so you get a little more information about them on there. Today, AfroPHC, together with JPIGO and the Wonka eHealth Working Party on Digital Health, have brought together an expert panel on this really timely topic of digital health and primary healthcare, universal health coverage. We have 5 panelists. Each of them will take around 10 minutes to share their unique perspectives, their experience with us to answer the question, how can we best use digital health to support primary healthcare for universal health coverage in Africa? And after that, we'll break into groups for some facilitated group discussions around the points that we've heard before we come back to a final plenary session. So that's sort of how the afternoon will be organized. Just to reassure you, slides and recordings, all of that will be available after the workshop on the website and be circulated. So everything that happens now, this is being recorded. This is also live on YouTube. Everything that happens now will be available after this. And again, thank you, all of you, for joining. So we're going to move right on into our interactive workshop. There's a lot to be discussed today. And the first of our 5 speakers is Dr. Steven van der Wijva. And he's going to be speaking to us on the global view on digital health. Dr. van der Wijva is a family doctor and director of family medicine at OLVG Hospital in Amsterdam. And he spent 3 years working at the APHRC, that's the African Population Health and Research Center in Nairobi, studying cardiovascular prevention amongst the urban poor. And he's a continued and strong interest in innovations in digital health, specifically to improve access and quality of care for the most vulnerable. So Steven, over to you.
Thank you very much, Radha. And well, it's a pleasure and an honor to be part of this session and to give a presentation about more from a digital perspective, from a global perspective, on digital health. And I think we have a critical question, I think, which is quite important, how we can use the digital health to support specifically the primary healthcare for universal health coverage in Africa. And I think there, the African continent is very well situated, because I think I've put 2 important elements which are essential in this case. And I think that is the free thinking, so to say, that you can really start almost from scratch. I think one of the first and one of the main barriers a lot of healthcare systems face, also where I'm currently active in the Netherlands, there's lots of barriers towards innovation. And I think the second important element is the mobile phone. And I think this is one of the most essential drivers for innovation and also for digital health. And I would like to talk in this 10 minutes a bit about where we're coming from, what's happening also in other fields. And then I would like to give a guiding example for everyone worldwide, but also specifically for the African continent, how digital health can be implemented. So, I just want to start that digital health is not something new. It is something which is already happening from the 50s, 60s, teleradiology, teledermatology. Then we had e-health, m-health, and now we talk about digital health. But definitely the spur of the innovations have started in the last decade, and it's now exponentially growing. And that's, of course, mainly due to the rise of the mobile phone. So here you can see that the majority now worldwide, including low and middle income settings, is having a mobile phone. And even of the mobile phone users, you can see that the smartphone users are also catching up rapidly. And as maybe a few of you know, the power and the impact of the smartphones we have currently, due to the increasing technology and strength, they are like full-blown computers we have in our pockets. And this can lead us to communication, but also diagnosing, measuring, treatment. So there are all kinds of elements how a mobile phone can be used. And here I want to show it's not just in health, where all these innovations are taking place.
Sorry, Steven, we cannot see the presentation. Can you put it in?
Oh, sorry.
Thank you.
I thought I am.
I can see the main screen, but it doesn't seem to be moving through the slides as you're speaking.
Okay, let me see. Where can you see it right now?
I think you have to put it in presentation mode.
I can see here. Let me see. I see here your screen sharing. And then let me see. I will try to share screen. Share. Are you now able to see it?
Yes, perfect. Thank you. Yes.
And is it now moving? You can see it?
Yes. Thank you so much.
Okay, sorry all, and thanks for letting me know. So I talked about the mobile phone, and I think the free thinking, where we can really start thinking, dream out loud what we want. And I will show you also the example how you sometimes can start from scratch. This is more about the timeline. This is the mobile phone users I was talking about. This is the smartphone users, I think, which is an important element. And here I was about the digital transactions in low mid-income settings. And like I said, you can see that 3.6 billion of the global mobile subscribers are located in middle and low income settings. And we use them also for banking, in the agriculture, in education, and of course also in health. And I think it's important, if you look at innovating, how you can also learn from other sectors. And like I said, it's often said, but I think there's an important value in the whole system of leapfrogging. That it's sometimes really, specifically in digital structures and innovation, that it can helps innovation to not have to demolish and break down existing structures. One of the main barriers for innovation in the Netherlands, where I work, is actually the current structures who are in power and who are not really opening up and want to give up their power and structure to start installing digital innovations. And like I said, this is not just happening in health, this is happening in education, in governance, energy, finance, but I think in the central of it, we're talking about health. And here, this is just one of the examples. I think if you talk about leapfrogging and African being very innovative, is of course the digital innovation of M-Pesa and financial e-banking, where you can see that this started 15 years ago in Kenya, and this has grown rapidly all over the continent. And when I was there in Nairobi, I was astonished how mobile thinking people were, not just in banking, but also when we worked on development and digital perspectives on cardiovascular prevention. I think we were much further ahead than where we were in the Netherlands. And also when I came back, it was almost stepping back in time. So I think these kind of innovations should give a lot of trust and confidence to build around these kind of developments. And then if you talk about where are we standing currently, you have the Global Digital Health Index. It's a group, it's not yet active anymore, but they did a kind of scoping of where countries are standing in how digital health has developed and integrated in their health structures. Well, you see there a few blue countries, but unfortunately most of them are gray, which actually means that there's not sufficient data to say something useful about it. But if you more look to the OECD countries, there's quite some thorough data about, well, what is then the most digital advanced country if you look at health system? And clearly on top of that is Estonia. And I would like to elaborate more on the case of Estonia, because I think it has lots of elements that where we can learn from. So Estonia is a very small country. It got independent in 1991 from the Soviet Union. It was just liberated from a dictatorship, so to say, where there was not much privacy. And then this country decided to be really independent, and where privacy for persons and patients should be vital. And there they decided to set up an e-health system already in 2008, which was like one of the first in the world. I think it's important to know there was a big thinking also in digitizing and digital innovations. Skype, you probably would know, was actually built through all kind of Estonian software experts, and now currently 99% of the healthcare system in Estonia is digital. So if you make a contact with your doctor, you can do it either through mailing, chatting, phone, Skype, or real life. And well, there are actually a lot of healthcare providers worldwide going to Estonia to experience how this works in reality. They have got a beautiful e-prescription system where it's much easier for people to repeat their medication, to have automatic interaction controls. There's an e-ambulance systems where if there is a sudden event and the ambulance is coming to your place, you have pre-filled forms after the ID is input, also in the emergency department. So it's all one continuous care, and the people can access their data. And the patient, it's really patient-centered. They can decide who has insight and who can share information. And it's all based on the important essential element of data privacy and the use of blockchains. So it has a high quality, it's very cost efficient and sustainable. And they're really working now on next steps. So also to have your personal background, even your genome involved for increased risk on cancer or cardiovascular diseases, where it will support general practitioners in the personal care. So it's really a transition also from curative to preventive medicine, and really developing personalized medicine. And they all built this up in, I would say 2 decades. And when they got independent, they were at the same level of income as South Africa. And they have really put this firmly and stable onto, they chose to have this digital infrastructure. And it's not just in health, it's also in e-taxing, e-education, e-land. And like I said, it's all centered around the individual who has access, and they can decide who can share that. Well, and what I want to say, this digital health is not just digitizing contact, but it's about thinking about the whole system, how you can have it more patient-based. The patient is in the lead. It's not doctor dependent, it's embedded in communities. It's more looking on preventive care, more on primary and universal health care. And I think therefore it has a strong value to focus on where we talk about today, on the primary healthcare and universal health coverage. Well, I think my time is almost up, but I just want to briefly show digital health. It's about many different topics. And I think a few of them will be discussed later in the session as well about the electronic health records. But I think it's important to think about the whole continuum of care. That's also when you talk about electronic health records, that it starts with the patient and it ends in the hospital, and in between there is the general practitioner or other healthcare providers, and they all share the same information based, of course, on the patient who decides. Well, here are some examples that probably you know, where innovations have started very rapidly at the Babi, Rwanda, the AfroPHC, maybe we'll talk about this afternoon. But I think here it shows how through your mobile phone you can get access to chronic care, maybe apps, chatbots, your own data. You can give health workers and other people access. You can see also if you can contact specialists, and the health workers, they can access the information. They can have decision support systems involved. And I think this is the system where really there's lots of opportunity and possibility, I think, on the African continent. Well, here are some WHO principles about the digital development, what to have in the back of your mind. And so design it with the user, design for scale, think about where the data is going, use open standards. And then I think there's lots of opportunity to develop a digital health environment in the primary healthcare settings of Africa. I'm looking forward to the other panel sessions and the discussions this afternoon. Thank you very much.
Thank you very much, Stephen. That was a great start. And I think digital health is not just about digitizing. It's going to be something I print and put up on my wall after this. I think you're absolutely right that it's so central to, to so much of what we're doing, and we can tend to be fairly narrow-minded in our view of that, but there's just so much out there. And I think this is the perfect time to turn to the second speaker, because she will be building on exactly what you've said. And I'm delighted to introduce Erica Troncoso from Jipaigo, who's going to be talking about how best can we use digital health to support primary healthcare in Africa. Erica leads Jipaigo's initiatives on emerging technologies and frontier solutions, including tech-enabled primary healthcare, which is a big focus at Jipaigo in the last couple of years. And really across the spectrum of emerging technologies, Erica very much looks at those innovations that are likely to have the most impact in low resource settings. So building exactly on what you said, Erica, over to you.
Thanks, Radha. Can everyone see my slides okay? Yes, okay, awesome. Great, well, thank you so much, and thanks for this opportunity to present today. I am a technical advisor at Jipaigo in the Global Solutions and Innovations team. And at Jipaigo, we have extensive experience supporting and working with healthcare workers, building their capacity to provide healthcare across a multitude of technical areas. And as Radha mentioned, now we are imagining primary healthcare as a key area that can help us achieve universal health coverage, and digital health as a key lever of that support. And so today I'll be sharing a bit about our thinking. To begin with, digital health, to start with digital health, best practices really include understanding and clearly defining the problem in order to appropriately apply and match digital solutions. Some of the struggles and key challenges to achieving primary healthcare vision, I put here on the slide, but this audience is probably very likely and familiar with these. I wanted to highlight two key quotes from our country teams in Africa that in regards to insufficient funding for primary healthcare, they remarked, "The most pressing gap is the chronic underfunding of primary healthcare. Typically, only 40% of national health budgets are going to primary healthcare, despite primary healthcare covering more than 80% of health needs." And another quote, when discussing the lack of comprehensive care, was stated, We have neglected the need to address a full set of issues facing local populations and instead focused on diseases instead of patient well-being in a holistic sense. And so these are some of the challenges that we grapple with when talking about primary healthcare, and especially how digital health can apply to solve these problems. So why technology and why digital health? Well, as Stephen mentioned before, we have seen significant growth in technology and enabling infrastructure, unlocking new technology-enabled primary healthcare solutions. So technology, including the mobile and internet connectivity, is becoming increasingly pervasive, with 80% of mobile penetration across sub-Saharan Africa predicted for this year. 1.4 billion more people are now online since 2014, and 58% of countries are developing e-health strategies. All of this is leading to growth in digital health products and services to deliver more personalized, coordinated, and care at a lower cost. And lastly, the WHO codifies this growing consensus that the use of digital health is an essential enabling factor in progressing towards universal health coverage. Sorry, this was the slide. So what does primary healthcare look like when it is supported by digital health? Well, it is increasing efficiencies to reduce in-person care, procurement, workforce, and facility costs. Like I mentioned before with the quote, costs are a big challenge, and digital health can help by providing insurance and reimbursement tools, client payment tools, inventory and stock level management, billing and claim submission tools. It can also increase the availability and quality of primary healthcare services. So specifically thinking about the health workforce, digital health can increase the scalability and quality of health workforce training through tech interventions. It can increase the accessibility of support for healthcare workers, such as in decision support. It can optimize the efficiency of the primary healthcare workforce, such as time optimization through task shifting. It can enhance the retention of these healthcare workers as well through status formalization systems. It can also optimize facility workflow processes and reduce access barriers for clients. Examples of this could be by improving client information systems and optimizing geographical distribution of primary healthcare facilities. It can also enhance decision-making for better population and facility organization and management. What this looks like is leveraging data systems and solutions for decision-making. You can implement data collection and management services, EHRs, using geospatial data. You can also use client and citizen-based reporting, such as PROMs, or client identification biometrics, and referral coordination systems. And lastly, we can optimize and efficiently manage supply chains by streamlining and coordinating stocks. You can streamline procurement and drug and supplies management, and check the inventory level management as well. And so a combination of tech-enabled solutions could, over time, help to reimagine primary healthcare that are more tailored to patient pathways and that seamlessly integrate brick and mortar and remote point of care. This visual depicts our vision of a rural primary healthcare system in the future, which is customer-focused and responsive to the holistic needs of care seekers. It's task-shifted with simplified technology, and it's connected between actors to enable the continuity of care. It's coordinated between levels of care, and it's proactive and intentional. Thank you very much.
Thank you very much, Erica. What an exciting vision to be working towards. That's I think really something that we can all align around, and also something that, you know, is a very lived reality for most of us who are in African context. So thanks for setting the scene for that. I'm delighted now to introduce Dr. Kobus Herbst, who's going to be talking to us about the demographic and health surveillance systems and their relevance for universal health coverage and digital health research. So I think, you know, another piece that fits into this model of what a digitally enabled primary healthcare system can look like for all of us. Amongst his many roles and accolades, Dr. Herbst is the director of the South African Population Research Infrastructure Network, or SAPRIN, and he has a passion for information, in particular the creation of data repositories to curate secondary research, including in primary healthcare. So Dr. Herbst, over to you.
Thank you so much, Radha, and thank you for the opportunity to speak to you. Ever since learning about AfroPHC from Shabir and your vision of universal health coverage through primary healthcare, I've been excited about using population cohorts, also known as health and demographic surveillance sites, to develop the evidence base for primary healthcare-based interventions to enhance universal health coverage, including e-health solutions. So let me tell you more about health and demographic surveillance systems, or population cohorts. I work with Shabir to try and develop an Africa consortium of these population cohorts to use that as a base for evidence to intervene and achieve universal health coverage for all. So health and demographic surveillance systems have worked from a geographically defined and spatially located population. So in a specific area, it could be in an urban slum, like our previous speaker at AfroPHC has a HDSS in an urban slum area, or it can be in a rural area, or any combination of that. Typically, these populations are anywhere from about 30, 40,000 to usually around 100,000, but there are also some large HDSs that are 250,000 people. Every person organized in households are followed over time to form a dynamic population cohort. What I mean by that is that the cohort grows through anyone born to members in the cohort, or that are in-migrating into this geographically defined area. But also people exit from the cohort, either by death, at which point a verbal autopsy is done so that there's accurate information about cause of death. And we all know that in Africa, there's a big lack in accurate information on burden of disease and cause of death. So in these populations, there's a lot of detail available on burden of disease. And then people can also leave the cohort through outmigration. And we also know how mobile populations are, and in fact, the important impact of migration on the difficulty in achieving universal health coverage. And we learn a lot about those dynamics from these systems. During this longitudinal observation of individuals, usually once a year, but in many cases, several times a year, you would make contact with at least every household and enumerate and make sure who have come in and out in the area, and you follow them up over a long time. And many of these systems have been doing this for 20 years and more. You can take biomeasures, there's genomics, embedded studies, clinical trials, etc., that is done in these populations. And I'll talk a little bit more about that later on. But very importantly for your topic is that often one link this population to health service records, educational records, social support records, administrative data. And that allows you, in opposition to what facility-based or a health facility-based record system can tell you, and only tell you about people that are actually attending the facility. in these sort of systems, you also know about people that are not attending the facility if you link all the records to the population database that you have of every single person in that population. And so it becomes a very powerful instrument to determine, to identify determinants of access to care and measure the impact of interventions to improve universal health coverage. What is very interesting is that primary healthcare and HDSs share the same roots. And one of those roots are the Phulela Community Health Center in South Africa that's started in 1940 by the Karks, Emily and Sydney Kark, in near the east coast of South Africa. And what they wrote in their own words is that we selected an area of homes overlooking the river, spread 6 to 8 miles along the hillside slopes. The nearest homes were 1 to 2 miles from the health center. There's no existing map of homes in the area. Was there any system of numbered addresses? Use field compasses to locate each homestead. Nowadays, we would use GPS. And so already at that early stage, more than 50 years ago, this concept of spatial information to determine health coverage. And then they talk about how it was important to introduce the health center address system and identify where people were that are attending the health center and who was not attending the health center. So all the components that you've seen in the HDSs that I listed below. And so there's also community health workers that carried out this demographic survey, basic epidemiology and health education with each family. They also did periodic updates to record changes in composition of households, as well as activities, agriculture, marriages, migration patterns. And as you know, this concept spread throughout the world to Brasilia, to the US, to Israel, and it was one of the origins that led to the Declaration of Alma-Ata in 1978. So let me talk a little bit about a few examples of how HDSs have done in Africa over the years. So the earliest HDSs that we know about was in Zambia, founded in 1955, looking at the social impact of resettlement to create Lake Kariba. In Yagar in Senegal in the 60s, recording, the idea was to say that we know very little about population sizes, etc. in Africa at that point in time, and the diseases that was prevalent and what exactly the level of prevalence was. But that site then developed in the late 80s as one of the important sites where measles and pertussis vaccine trials were done, illustrating, for example, also the detrimental effect of high-titer measles vaccine and really optimize measles vaccine to the level where today it's an absolutely crucial component of the expanded vaccine program. In Farafenni in the Gambia, it was established to evaluate a village-based primary care program and later became a very important site for malaria research. In Navrongo in Ghana, was the place where vitamin A supplement to reduce child mortality by up to 20% was shown, the evidence for that. In Ethiopia, it was established by the University of Addis Ababa to build capacity in epidemiological research. And one of the students that did his master's at Butajira is now, of course, the Director General of the WHO. Masaka and Rakai in Uganda was really where a lot of early work on the epidemiology of HIV in Africa was done. And PHC in Nairobi, it was one of the first urban HDSs in Africa, looking at the impact of slums on health outcomes of urban migrants. Ifakara, Tanzania, trial of the effectiveness of bed nets on morbidity and mortality of children, showing 27% increase in survival. And Malawi, tuberculosis epidemiology, the first evidence of decline in population mortality due to introduction of ART. In South Africa, first evidence of increase in life expectancy due to ART introduction, and also showing the superposition of chronic infections of TB and HIV with non-communicable diseases of hypertension and diabetes, and the important concept of multimorbidity and how crucial that is in the burden of disease currently. So there are actually quite a number of these HDSs in Africa, about 37, and also a whole number of additional population cohorts where I think useful collaborations can happen, pursuing interventions aimed at improving universal health coverage and evaluating interventions such as e-health interventions that we've heard about already by the first speakers. It shouldn't be a surprise, of course, to members of this audience that Africa is particularly bad at effective UHC coverage, and there's a lot of work to be done to improve it. So to end up, then what do I think is the relevance of these types of HDSs to your work? One, as I mentioned right at the beginning, it had this important dimension of those not accessing health services to understand the determinants of that and design interventions which could include e-health to address that. It can host health system intervention studies using both traditional experimental as well as newer quasi-experimental designs to build the evidence base. It allows us to study the multidimensional and multi-level factors impacting on universal healthcare. We know that there's individual level factors, household factors, social factors, political factors, a whole host of really complex interacting factors that determine lack of effective universal health coverage. And in these population laboratories, so to speak, one can disentangle those complexities and develop insights that can then be developed at a larger scale and rolled out at national and regional level. It forms then also a base for multidisciplinary teams working across traditional disciplinary boundaries to solve these problems. It has a manageable population size to pilot and refine interventions before going to scale. And I think also for e-health, because often, and I see many of you are advocating that, is this co-creation with participants for e-health solutions, and that provides also a context within which this co-creation can happen. And finally, the longitudinal nature and geographic containment allows for meaningful community involvement and co-creation of interventions. Thank you very much.
Thank you very, very much. That was fascinating. That slide with the images across Africa really makes you realize the wealth of information and data that we have across the African context, and it's exciting to think about how we can apply that to move primary healthcare and universal health coverage forward, particularly around the sort of underserved population. So thank you for putting that idea in our minds. Keeping on the theme of data, but now very much looking closer to the individual client, we have Professor Andrew Poole, who will be talking to us about electronic health records in Africa. Professor Poole is from the School of Public Health and Family Medicine at the University of Cape Town. Professor Poole, over to you.
Thank you very much for the invitation to present at this meeting. Can I just check that you can hear me?
Yes, we can hear you. Thank you.
Great, and that you can see my screen.
Yes, thank you very much.
Great. Yeah, so I'm a public health medicine physician working in a provincial health department in South Africa. And I've been working in health information systems now for over 2 decades. And I'm just going to share a few perspectives on the kind of maturation cycle for electronic medical records in our context, another resource constrained context. So when I started clinical practice, I was given a sheet of zeros, and I was told to mark off a zero every single time I saw a patient, and that at the end of the month got added up as part of the monthly headcount statistics. And I think it's quite sobering to note that in Africa, in many parts of Africa, and in fact many parts of the world, aggregate reporting is still the mainstay of public sector health system reporting, premised on this notion of a minimum data set where indicators are very clearly shown and are very clearly selected in a kind of an action research approach, and cascaded upwards a smaller and smaller number of indicators until a very small number are reported nationally and internationally, and the whole process for reflecting on data and service improvement. But where we want to get to is a much more individuated electronic data environment where there's an electronic medical record. Clinicians operate paperlessly with a single sign-on and what we see in the movies. But where we've ended up in a lot of countries is with quite a lot of digitized health data, but not necessarily that well coordinated. So there may be patient registration systems or high throughput systems that are digitized by force of circumstance, and that they have to be digitized to achieve the scale that they need, like high throughput pharmacy dispensing systems or laboratory systems. And there's quite a lot of electronic registers developed for specific priority programs like HIV, TB, malaria. And this in the hospital space, there's been some work on discharge summaries. Putting it all together, we've tried to kind of capture the move from the DHIS style approach to the use of individuated data, and we've borrowed the notion of second generation HIV surveillance to talk about second generation health information systems. And it's moving from aggregate to personal, aggregating the reporting data from unit data, moving from minimum data sets to person-centric administrative and clinical data, etc. I won't spend too long on that, just to note the paradigm shift. And previously we've identified this kind of move from aggregate to having some paper-based registers of cohort patients, to making some of those registers electronic, to sometimes reporting those data from a register centrally, to having an online register, to having an EMR that gets entered after from a paper clinical record to a kind of point of care paperless system. The context in which to trying to get this to the context in which to integrate it all is often it's often proposed that we use a health information exchange approach, and a health information exchange is it allows flexibility of multiple different systems to integrate. So we frequently encounter systems. So our first speaker spoke about the mobile phone revolution and frontline workers, solutions for frontline workers, where a particular cadre of workers in a particular jurisdiction all have a system that interoperates with, where everybody's part of the same system. But that system doesn't speak to the rest of health data collected in quite disparate information systems. But if they can all coordinate through an exchange, then it's much more flexible. An exchange has core components such as a client registry, a facility registry, a provider registry, and a terminology service. many countries' e-health strategies now talk to a health information exchange. So this is the South African Health Normative Standards Framework articulated through the e-health strategy, where you can see the registry components. They talk about the patient registry or client registry, provider registry, facility registry, clinical repositories or shared health record, and the exchange components. And I'll just share briefly how this evolved over quite a long time frame in the province where I work, where initially all the hospitals were on one system and shared a folder number. You could go to any hospital and receive the same client registration details. And then they bolted on the primary care system, so the primary care could check if the patient had a folder already in the hospital system, and if not, create one and write it up. If they did, they'd pull it down. So the same number was shared. So this is a very basic 9-digit numeric with a modulus 10 checksum, devoid of any personal data. So this number is used across the entire system, and it enables data that's digitized from different systems, pharmacy, laboratory, from some of these disease registers, all to be centralized in an exchange. And it doesn't matter if the data are collected at point of care, after the visit, sometime later, and often sometimes registers sent in on paper long after the service was delivered. It allows it all to be consolidated around a shared patient record. We have such an exchange, we call it our Provincial Health Data Center. The most important thing is that it's oriented around clinical care, not analytics for any reporting organization. And the analytics come free if we can get the clinical care correct. And so we try and, linked on the unique identifier, we try and centralize all of these data from different systems, the hospital and primary care systems being key, laboratory and pharmacy being next most important, disease monitoring. The most important part of this data center is not any technology, it's the people. It's having the data competence to work with data at scale, which is a very different workforce to the DHIS workforce that preceded this. Another key difference is that we infer health conditions based on the full breadth of data available to us. So many of our health conditions, like being treated for HIV or being treated for diabetes, the drugs themselves are indicative of the health condition, and often the laboratory tests are similarly. So if we take all these different domains of data, not just the diagnostic codes, and we combine it in a phenotype algorithm, we can identify, we can consolidate it into a summative evidence that we have a particular episode of interest, and we can bolt on additional data that makes this data useful for care. There's often a bit of tension between national and subnational levels around where this data consolidation should take place. And from experience, we have a very strong impression that we have to strengthen all levels. It's not an either or. There are some systems, the client registry, the laboratory system. So these acronyms won't necessarily make sense to everyone, but the client registry, the laboratory system, the provider registry, maybe the facility registry, that should be nationally housed. But there's many very peculiar local systems where no national system would have the capacity to curate the data from all these different ambulance and pharmacy and primary care and community worker systems, that if the subnational workforce can curate those data and report it in a standards compliant way nationally, and also draw down data from the national systems, we have a virtuous strengthening of both levels. Putting it all together, there's huge opportunities for preventive approaches and managing with a population lens and not a curative lens. So all the data from all these different systems consolidate in the exchange. We can then use the exchange as a digital safety net, especially if we've got a communication channel directly with the patient that is safe and secure, so that patients can authorize access to the data or consent to services, or even request or receive services via this channel. So patient-facing interfaces are absolutely critical, and also the consolidation of data to optimally guide care. And many of these new innovative, decentralized or models of care that use novel delivery mechanisms The most important thing is that those data integrate into the exchange and do not try and parallel integrate directly into the facility, because when that happens, then there's only one system that benefits. But if everything integrates through the exchange, then, and especially using standards, then it makes it much easier for the next system and the next one and the next one after that to integrate for patient benefit. So in terms of sequence of activities, in terms of getting there, I think there's no doubt that building the core underlying registries, the client, provider, and facility registry are absolutely essential. And I think most countries have initiated that work. And thereafter, there are some things that I think a lot of rich countries will have done many of these things 2 decades ago, and this will be very familiar. But for example, in hospital practice, the time it takes to write a discharge summary by hand makes it an incentive for a discharging clinician to capture that discharge summary electronically. And in capturing electronically, the data can persist for all users. So starting with electronic discharge summaries as a single digitization moment of hospitalized care is a very good quick win, bolted onto the client registry. Digitizing laboratory data, we already fetch the specimens and have to centralize them often in laboratories. So digitized laboratory data are a huge is a quicker win than digitizing care at every single facility. That breaks down a little bit with point of care testing. And in primary care, trying to, when everything's in paper and you digitize the first program, then we go electronic for one register. But when you've got 4 different registers, all electronic and often on different systems, it becomes completely fragmented. So using an integrated approach, having integrated clinical stationery on paper with a single digitization moment for that stationery. And as maturity develops, there will come a time where instead of a clinician capturing this as our integrated stationery, 1 column per visit, instead of the clinician filling out this 1 column, they will actually capture directly in the consulting area. But the notion is that there's only one place where data are captured during a visit. Everybody knows where that place is. And if it's on paper, there's one digitization moment, no matter how many health conditions that patient has, rather than lots of separate electronic registers. And then there are high throughput areas in some primary care facilities like pharmacies where the dispensing can be the next target for digitization. And just to emphasize the point about making sure that all integration happens with the hub or with the central exchange to maximize opportunities for the next integration. Thank you very much.
Hi everyone, sorry. I think Rad has just had some challenges with internet. So I'll just quickly pick up and let the next speaker go. We are very fortunate in having Mr. Gugu Newman, who is from South Africa. And Gugu is basically a co-founder and COO of Ribbon Blockchain, a for-profit social enterprise that works with blockchain to basically look at public health systems, build in efficiencies and look at data. So I hope you're going to get an idea of blockchain. And I think most of us seem to only think that crypto is the only way in which blockchain works and Bitcoin. But the technology is actually quite handy for a lot of other things. Let's see, Gugu. Over to you, Gugu, thank you for joining us.
Thank you, Professor Musa, and good day to everyone. Can you hear me? And can you see my screen? Can everybody hear me?
Yes, we can.
Okay, perfect.
Yeah, we can hear you and see your screen. Yeah.
All right. So I'll get straight into it. Thank you. So we are basically a company that's looking at using blockchain in primary healthcare. And our approach is pretty simple. We're basically using blockchain to build a protocol and a platform for global public health, right? What that means is like we're kind of like building an operating system to run global health or public health or primary healthcare. And our approach is a bit creative. So we sometimes, are a little antagonistic with existing healthcare ethics and healthcare practice. So we're very future focused, right? And you'll understand why along the way. So what have we looked at? So blockchain, like I said, is an operating system in a sense. It can do a lot of things, right? It can do just about everything that some of my esteemed panelists have mentioned earlier. However, we've looked at use cases that can be implemented over the next 5 to 10 years, basically, and that could have the biggest, impact in public health or in primary healthcare. And those two areas that we really looked at and we built solutions for was longitudinal healthcare and longitudinal health records, as well as the funding for primary healthcare in Africa, which is a huge problem. Okay, so just to sort of give you a summary of blockchain, right? So blockchain, like I said, is a software system. It's a technology, like an operating system. However, it uses a common ledger. So normally each blockchain would use one common ledger. So all computers within that network would be linked on a peer-to-peer network and would have one set of transactions. So it would almost have something similar to a database. However, it's like a huge global ledger in this case. And how it works is that a transaction on a blockchain, so if you're sending money to somebody, for example, or a patient goes for an HIV test, for example, that gets recorded as a transaction. It gets put into a block of transactions, right? And those are that block or those blocks are broadcasted on a network. And that process of broadcasting will update all the computer nodes on the network. So if we imagine everybody on this call sitting in front of their computer had a copy of the blockchain, all the broadcast would update all of our computers. So we'd all have the same source of information in real time. Or within 10 to 15 minutes at the same time. So that block then gets added to a chain. That's why they call it a blockchain, right? And then the transaction gets verified and executed, and then it becomes, immutable. So it can't be deleted and it exists on the blockchain. So you can audit those transactions, you can print out that whole ledger and query it and so on and so forth. So now going with the first thing that we're looking at solving is the issue of longitudinal healthcare, right? So some of my colleagues have spoken about like digital solutions in primary healthcare, right? And one of the things that come up when it comes to technology really is that technology is really used to bridge the gap in administering care within the healthcare system, from our understanding as software developers. So what we looked at was the social determinants of health, and we realized that about 80% of that is actually stuff that happens outside direct care. So there are socio-economic factors, the environment, healthy behaviors and stuff. And a lot of our technologies are not really robust enough to capture all these other events that are happening outside of the healthcare environment or system. So anyway, these digital solutions are normally, used in healthcare as e-health or electronic health systems or mobile health technologies, and they have their own challenges. Like mobile healthcare, which because of the high penetration of mobile across Africa, a lot of people have access to mobile. So a lot of solutions are being built for patients, for health workers, and for the institutions or the healthcare providers to use via mobile because it's easier adoption. However, mobile health have already come with some problems, such as, the developers of this stuff is usually ad hoc. The data is siloed, there's weak security, and so on and so forth. And it's higher risk for government and high cost for government to implement as well. And I think we've seen with the recent changes in the POPI and, a lot of these mobile technologies don't align with Health Act or that don't comply with POPI and so forth. So what blockchain allows us to do is to fix the problem on the highest level, so on the platform and protocol level, where we can actually, sort of structure a standardized approach where you can have standardized trust, verify every transaction, have proof on a common ledger that's auditable, and have a system that's actually open to all these other different technologies that are being built by private individuals, NGOs, and corporations. So blockchain is almost like, a thread that sort of ties everything together and allows us to have this standardized approach where we can verify and check. So in that way, you can start to have one single source of truth when it comes to medical records and so on and so forth. And you can actually start to port them globally. We've seen with the issue, for example, with COVID certificates, COVID vaccine certificates, where It might work in one country, but you can't go to specific countries, and they might not regard it as, depending on which country you come from, it might not be regarded highly, and you have to quarantine, etc. So blockchain allows us to capture all this information universally, where everybody can understand that certain standards were followed and that this information is true. Okay, so as that said, it allows us to have one single source of truth, and where we can link all these social determinants of health with whatever is happening within direct care. Okay, and what I'll show you here is an example of how a blockchain transaction would happen in a real world environment. So this is an old clinical algorithm for HIV pregnant women. So a woman who tests positive. So if we're using a blockchain system, so I just assume I'll be a community health worker, perhaps capturing this information on my tablet, or I'm a doctor or my nurse. So the patient would come in, and I would record the patient's name and that they're HIV positive, and that information would be recorded as a transaction on a blockchain within the app. So on the app, you just type in all the information, but on the back end, the blockchain would record this as a transaction on a ledger. So they have a reference number, it would have a transaction number, etc. And we could actually incentivize those patients for testing, for, say, taking that HIV test. So they could be paid in some cryptocurrency, which is something that our system does. And then when they go for their blood test and we check their CD4 count, we could incentivize them based on, what CD4 count level was preferred within that environment for them to be healthy. Or if it was below a certain amount, you would record that transaction as well, and you would not incentivize them. So you'd incentivize them whenever they are improving their healthcare. So now the blockchain in this instance is doing two things, right? It's recording the information on a ledger, okay, where anyone can access, any doctor anywhere, for example, who has access will be able to review this patient's records, right? And it will be like an immutable record. So it can't be deleted, it can't be, messed around with or whatever. So it becomes a source of truth. And the second thing we could do is incentivize that patient. So pay them basically for, making the effort to check their status, to get onto treatment, and to sort of like maintain a healthy lifestyle and the CD4 count. So in each of these processes within your clinical algorithm, we would record that transaction on a blockchain and incentivize the patients based on the outcome. So that's just an example of what the blockchain does. It records every single legal interaction or process within the healthcare system, right? And then that ledger would look something like this. So this is actually a real ledger on a blockchain, right? So this is what the transaction ledgers would look like. So it's anonymized, right? So you won't have anybody's name or whatever. The only reason I have a name here is because this is a ledger for it's for our public profile for my company, right? So we get grants and stuff like that. So we've given it a name and it exists on the blockchain. But for most patients and any users, there wouldn't be a name there. There would just be like a wallet address, which is a random number like this transaction hash on the left here. So every transaction will be recorded. So you'll be able to sort of audit, and it can be processed as a financial transaction or a zero value transaction. But ultimately, it will exist on a ledger where you can audit exactly what happened. So you start to get a little bit of data provenance as well. So in summary, within longitudinal care and records, blockchain helps fix the e-health and m-health problems on a higher level. So that's what we call a protocol level, a platform level of the health information system. And then it forces all other apps and that are built around the healthcare system then to adhere to these set standards. So whether it's POPI standards or the Health Act and so on, and the ethics, etc. Blockchain allows us to build a layer where all other apps have to implement all these changes, and then all the changes are then maintained on a protocol and platform level. So the protocol layer would work directly like with Department of Health, NGOs, and all these other entities that are our stakeholders to make the necessary changes. But then you can also implement voting systems where patients, community health workers, and health workers rather, can have a vote in how we change the protocol and platform. So that's another beauty about blockchain, is that there's a governance system that allows everybody to vote on certain changes. So it's not based on whoever is building the software, whether it's government or whoever has the money. It's very democratic. Now, the second issue that I'm going to look at is blockchain for funding primary healthcare or public health and so forth. And I know we have this gap, health financing gap that's been around for a while, which is around 176 billion, right? And I think it affects Africa and emerging economies more. So blockchain in a nutshell, right? In as much as it's a software, it's also a financial technology, right? Which runs on a ledger system. And the financial aspects of blockchain are what we call cryptocurrencies. So cryptocurrencies are like little apps that are actually built on top of a blockchain, right? So your Bitcoin, Ethereum, Dogecoin, etc. And these currencies have a market cap of around 3 trillion US dollars at the moment, right? And they are just used for speculative investment in most cases. Very few real world use cases. However, they were designed with the social issue in mind. So cryptocurrency in a nutshell is socialism, okay? But capital is socialism, let me put it that way. So, so cryptocurrency comes in there's two popular funding mechanism for funding for cryptocurrencies, how you raise money for a cryptocurrency and how it makes money. And the first one is what they call an ICO, an initial coin offering, where we sell, the coin to other people. So like the first Bitcoin that was made, the guy who made it, Satoshi Nakamoto, and nobody really knows who he is, but he was able to give out a few of these cryptocurrencies and sell some or put it on an exchange and sell it. So other people came in and exchanged their US dollars for this cryptocurrency. And the more people buy into it, the more it gains value over time. And the more it circulates, within this network, the more it gets what you call network effect, which is, the value of that coin. If it's worth $3, the network effect of that currency based on the number of users could be the 3 to the power of 2 or 3 to the power of the number of people within the network. So that's why the price goes up very quickly. It all follows this mathematical algorithm called network effect, right? Which is really compounds a lot. So we could use some of this technique like initial coin offering to fundraise for primary healthcare. And the other one is decentralized finance. Decentralized finance is a financial system that works on the blockchain for cryptocurrencies, where you can get loans, you can lend out your money and earn interest from it. You can borrow directly from other users or just from algorithms or platforms that are on the blockchain without a bank, without a middleman. So you don't need your identity or anything to access the financial system. Anybody can just download an app and get in and exchange money for cryptocurrencies and be able to access these financial services. So this really democratizes finance, and this could work very well for fundraising within cryptocurrency, within the primary healthcare sector. So the ICO funding model, so using it for public healthcare or for primary healthcare, we would ideally, our idea is we would launch a currency for universal health coverage. So we could launch something like a UHC cryptocurrency, right? So similar to Bitcoin, you'd have a UHC currency that works for all of Africa's, primary healthcare or public health. And how we'd do that is we'd crowd sell it. So we'd create this token, mint, something like 1 billion of it and sell it to people with Bitcoin and other cryptocurrencies. They would buy it based on the number of people there are that use the public health system in Africa, because cryptocurrency is a numbers game as well. So the more to potential users, the more utility it has, the more value it will have over time. So that will be one way of funding primary healthcare, is to have this cryptocurrency. And all clinics, institutions, governments are issued a specific allocation of this, and individuals can buy in and so on and so forth. So that could raise very, very, very money very quickly. That cryptocurrency could also be used to incentivize patients for improving their health outcomes, right? Or incentivizing, health workers for improving quality, and then incentivizing the supply chain for, delivery of drugs, etc. on time. So you could use it like as an incentive system as well. And this creates obviously a sub-economy where now you have this sub-economy, because beyond just the cryptocurrency, there'll be other services that it can buy. And this is what you call network effect. There'll be downstream revenues that are created by this cryptocurrency. And this can, it can be a sub-economy that exists outside the middleman, outside the banking system. The banking system comes at the end of the line, where somebody wants to cash out this universal health this UHC coin for cash. That's where the bank comes and is the middleman that sells the cash to that person and gets a commission. So the other option is decentralized finance, right? Which is this banking system of loans and credit. So within the system, we could create like infrastructure bonds to build clinics, right? To build primary healthcare centers. We could create social impact bonds, decentralized social impact bonds for specific health programs like your HIV or COVID, whether it's for testing, whether it's for, adherence, etc. And then you could also create like a decentralized, DeFi marketplace for health data trade and monetization. So we could sell health, analytics, health, not records per se, but the analytics and the insights that we gain from records. They could be sold on this platform as what we call NFTs, or it's like a version of a cryptocurrency that represents specific records. So we could also have decentralized finance, health insurance and funeral insurance, micro insurance for low income groups, where they can start to buy insurance, whether it's savings and pension funds, etc. You could have all types of insurance using this universal health coverage token within the decentralized finance system. And of course, once again, this creates the sub economy for primary health care within the decentralized finance sector. So a case study, just to give you a brief, not really going to show you a case study, but this is actually happening in real time and it's been successful. So El Salvador, a country in South America.
Gugu, sorry, just to give you, we've got about 2 minutes left, if that's okay.
Okay, yeah, this is probably my last slide. So El Salvador legalized Bitcoin, the cryptocurrency, earlier this year. And within a couple of months, they've saved, I think, well, their projection is that they'll save $400 million a year in remittances because they've got a lot of people that works abroad. And they're already looking to build a state veterinary hospital worth $4 million from the profits that they've made from Bitcoin. So they've bought a whole lot of Bitcoin. When the price went up, they sold some, and they are using to build hospitals. They're using to fund public services and to build new schools, about 20 new schools. So this is happening in real time. And there's an opportunity to do this, not just for countries, but for specific areas like healthcare, social services, and so on and so forth. So yeah, so that's where we are really looking at using the blockchain as a funding mechanism and to sort of map our longitudinal healthcare and health records. So thank you very much.
Sorry, I was struggling to unmute. Thank you so much for that. And personally, thank you so much for explaining that in a way that some of us who kind of panic when we see the words like blockchain and cryptocurrency. Thanks for explaining in a way that we all understand. We are running pretty tight on time, but I think we have a couple of minutes for questions. So if I can ask if anyone has a question, you could either put it in the group. I think I see one already, Gugu, that's directed at you. It says the concept of cryptocurrency is entirely new to me. How does it function and who controls it? If you wouldn't mind taking a minutes to answer that. Anyone else who has questions, either please put your hands up or put the question into the chat.
Okay. So cryptocurrency really is like money, right? It's a form of money that's generally currently used for it's like shares. You go and buy shares at the stock exchange, or you buy bonds or whatever. It's an investment vehicle, right? But it can also be used for transactions. Like you can use it to buy bread, to buy McDonald's. They're doing that in Salvador. You can buy McDonald's or buy anything even from $1 and so forth. So it's money. It's just digitized money, right? And who controls it? Usually cryptocurrency is not controlled by anybody. But however, technically it's controlled by the people that have the most of it, right? So in Bitcoin, if I have 20% of the supply, I can affect the price. If I sell, then everybody sells, the price goes down. So, but however, nowadays there's what they call a governance model, where most cryptocurrencies are issued in a bit of a slightly almost fair way, where the majority of holders have got a vote. So it's democratic. So you have a vote on a lot of things that affect that specific cryptocurrency. So it becomes a little more democratized. So the newer ones are more democratized. The old ones, slightly centralized with people that have the most of them. Yeah, but it's designed to be not owned by anybody. So no government can censor it or stop it and so on and so forth, or print more of it. Yeah.
Great. Thank you very much for that very important question and for that excellent answer. Any other questions, any pressing questions for any of our 5 speakers, panelists as yet? Please feel free to put your hands up or to type it into the chat. I don't see, oh yes, Harry, would you like to go ahead? Please unmute and feel free to ask your question. Harry, I see someone, Harry Ben Alpha, your hands up. Please feel free to ask your question. If you can unmute, I can unmute you. You have a question?
All right. Yeah, hello, how are you? Hello?
We can hear you, thanks, go ahead.
Yes, okay, I'm sorry, thank you very much for the wonderful presentation. It's a very good area that we are learning from the digital health. And one thing we are coming from communities, we are community organizations working on community-led monitoring and other interventions. So we are very keen to really have a good and productive information on the use of digital health in improving our work. So I really want to know how you people can help to bring in communities in order for us to build our capacities in terms of use of digital data collections in terms of our community-led monitoring that we are doing. So that could be actually wonderful for us, because I see all the presentations here are very wonderful. And I still want to make sure that we are also part of this process. Somebody else can facilitate how we can get communities involved in the use of digital in terms of our health monitoring we are doing. Thank you very much.
Thank you very much. I think that's such an important point, you know, the engagement of communities as we look at these digital health options. Any of the speakers, did you have, if you'd like to respond to that comment? I think it was a comment more than a question, but it's certainly something for all of us to keep in mind as we move forward. And I think something that AfroPHC is specifically seeking to do, which is make sure that the right communities are represented. But if any of the speakers would like to respond, please feel free to unmute.
Yeah, no, thank you very much, Harry. I think it's a very good comment. And for me also, I think as a general practitioner, I like to be as pragmatic and concrete as possible. And this is, of course, indeed giving all kind of different information and inspiration. But from my perspective, I would love to see in what way we can think about concrete options to the community. And I think we discussed about several groups, as Kobus was saying as well, through digital demographic health sites. I'm in contact with PHC to see what we can do there. But I think it's good to inform each other in this network and what kind of opportunities there are for funding, for projects, for initiatives, and to see how indeed the community can benefit from this. So I think we have to keep all our ears and eyes open to see when these kind of opportunities come by.
Thank you, Stephen. In the interest of time, I am going to hand over to Ana Neves, who is going to be leading us through the next portion. Please do keep your questions and comments coming through on the chat, and we'll make sure all the speakers, panelists, please keep an eye on the chat in case there are questions you can answer there directly. And Sankire also, please, Anna and Sankire will be leading us through the next bit, which is the focus group discussions in small groups. Anna, over to you.
Yes, thank you, Radha, and nice to see everyone. So yes, my name is Ana Luisa Neves. I'm a GP by background, and I'm also a researcher at Imperial College in London. And we are quite interested on studying digital technologies and, of course, how to make them safer, better, and more patient-centered. And just to give you a little bit of background and how we land here, actually, over the last year, we actually ran a study in 20 countries, trying to understand how different countries were using digital technologies. And we ran this mostly in Europe, America, Australia as well, but we missed the opportunity to also hear the perspectives of providers, patients, and other healthcare providers in Africa region. So we were aware that there was a gap there. We were just waiting for the right opportunity. And as part of a few discussions with Shabir, we thought it would be also important to engage African countries as part of this discussion. And I think these presentations that we've heard today are just, I think they are just really so exciting because it shows us how much work is happening already and how much we can actually learn from each other. So that's the background, and that's why we land here with our team. So what we'd like to do now during the workshop is actually to split in smaller groups and take a step back and try to reflect on how are we using digital technologies and do a bit of a SWOT analysis, trying to understand which are the positive things, what is going well, what can be even better for the future, and which are the challenges, the things that we need to improve and how to do that. So that's basically the aim of these breakout sessions. So I think Sankire is going to help us to go into breakout rooms. But before that, I just wanted to share just 2 thoughts with you. We will run first a quick poll so that you understand a little bit about each other, try to understand which are the roles of the people that are here, which is the background. And then Sankire will send us back to the breakout rooms. Would you be able to start the poll, Sankire, or would you need me to do something?
And just to confirm, you were saying that
perhaps I can just quickly help Sankire. I'm not sure that you can see the breakout room. Okay. Can I just ask quickly that people provide us their hands up? I'm going to put up the poll in the meanwhile, so that we can see who's actually in the meeting. So if you don't mind doing that. And then if you are French speaking and prefer to speak French in the group, just lift up your hand and I will just make sure that you land up in a French speaking group. Okay, so pick up your hand. If you could just lift your hand. Yeah, the hand basically, if you go to more or reactions, you can just click on that and you should see that you can raise your hand like I've just raised my hand now. So just quickly, anybody who feels more comfortable in French, just lift your hand. Okay. Keep going. If anybody else feels that they want to rather communicate in French, please do that now. Lift up your hand. And I'll just add an F when we break up into groups. We'll try and get you into a group that is better speaking.
I think we're not able to answer the poll. It's showing up as the results, but we can't seem to select.
Okay, let me just redo it quickly.
So how many in the group? How many groups? Is it 2 groups? 1 group?
Yeah, if we just get a sense of the languages, I think quickly, I think you are now able to put in, so go for it. You can just enter into the poll. I think there's a problem with the poll.
Yeah,
so
I don't think we're still
doing it right. Okay, nevertheless, we'll do the poll a little later. If you don't mind, I just quickly get everybody named. Ah, okay, somebody else is trying. It's great. Is it working? Serge, I think, let me just add that to you. I think we want the different languages to be comfortable. So I've just got Abdulrahman or Ibrahim and Serge and Gamba. Anybody else? Nobody else? Okay, can I quickly ask if anybody, okay, you can put your hands down. I'll just lower it for you. If you can pick up your hand if you feel you're comfortable in Portuguese. Portuguese, anybody who feels they want to talk Portuguese? Oh. Okay, it seems like nobody. And Spanish? Anybody wants to speak Spanish and prefers that? No problem. Okay, we will just give the poll a chance. I think we want as many people as possible to fill that poll. And as soon as the poll is done, we will break out into groups and then the rest will continue. Okay, your facilitators will be in each group.
Xavier, I'm happy. I'm not sure if I'm already on the French group, but from our side, from Imperial, I don't mind being in the French one.
Not a problem. I think
Okay.
let's just get many people to fill in. We've only got 10 out of 31 participants who've given us their sorry, I'm caught with 2 different meetings. Okay, we only have 11. Can we get a few more people, at least half? Half of the people, and then I think we can just stop it at that. I think I would then suggest...
feeling, Shabir, any of us who are on as co-hosts, we're seeing the results, but we're not able to put in a detail. So if you're panelists or if you're supporting...
That's probably a reason why. So can I just ask that in the discussion, we can just try and answer those questions. I'll share the questions within it, and then we'll try and just get that through that. I think it's perhaps slightly challenged. Okay, I think we are 13. If we can't go any more, then we'll stop there and break up the group. Thank you.
Sorry, Shabir and Anna, I just wanted to ask, I think you were going to talk a little bit about, so this bit will not be live on YouTube, right? Anna, you were going to talk about that, and then the consent, please.
Yes, yes. So we'll do that again as part of the initial at the beginning of the focus groups. But yes, so these will be internal discussions, so just the group. So these won't be live. Of course, the discussion when we are together again as a panel, that's different part. And of course, the only thing that we'll ask you is if you are happy for us to analyze this data and come up with some conclusions from a research perspective. So if anyone is not happy for us to use your answers to try to create any kind of report or academic paper, just let us know now, and we'll of course not use the information that you'll create. So our objective with this is try to extract as much knowledge from this very diverse group and to come up with a list of recommendations on how to work together to improve digital health in the Africa region. So let us know if you don't consent to use for research purposes, and we'll remove it from there, of course.
Okay, I've opened the rooms, and there's some unassigned people, and I'll just assign you if you just give me a few seconds while we just do that.
Shabir, will go for 1 hour, right?
Yeah, just give me about 2 minutes. I think it's just a question of getting them each assigned to a group, and it's a little bit touchy sometimes. Takes a few seconds because we've got a lot more people added in. I should set it up a little later. So sorry about that. All groups will speak English. So additions. Almost there. So your breakout rooms are open, but I'll just ensure that everyone is allocated. So. Sorry about this. Zoom's breakout rooms are a little touchy to work with. Give me a second.
Seems they are going to close the rooms, right?
Okay, give me a few seconds. Everyone can join the rooms. And I think you're free to do that. I'll just assign people, so it should be fine. All of you can join your rooms. Those who are still not in the chimed, I will assign you. Just give it a few seconds.
One is Spanish. Where do I join? I am seeing Port Spanish.
Yeah, don't worry about the Spanish. It's actually English. So just go into that group.
Okay.
It is English. So just get in there. There are no Spanish speakers. So it should be all right. Apologies for the little confusion. I'll rename it so you don't feel confused. Okay, everyone's assigned, and I think you are all able to join the groups and continue the discussion.
Yes, Shabir, may I ask you just 2 questions? So we are running a little bit late. Are we still doing 1 hour?
Yeah, let's keep it to 1 hour. Otherwise,
Okay.
we will risk, I think, even to that 53 minutes.
Okay.
We can then have a half an hour to close the discussion.
Okay.
I think we get some feedback.
So you want us to finish, sorry, at 1:30?
Half past the hour.
Okay, that's good. And the other thing I was going to tell you, so Lana from our side is in the French breakout room and she doesn't speak French. Maybe it's a good idea to swap Lana by myself because I speak a little bit of French.
Okay, is it? Yeah. Okay. Let me just quickly find that. But the French group, I think.
I'm sorry. I'm sorry, Professor. I keep being directed to Mercy's breakout room.
Who is that? Nikki? Later.
Yeah.
Anyway, if they are not speaking French, Lana should be fine there.
Yeah. I think first join later and I will then move you.
And then I think there's still about 12 of us, Shabir, who are not in any groups or can't seem to join any groups.
Okay. I think what you do is join the group and then exit the group. It might be easier for me to then do that. And
we were all told, I'm not sure about everybody else, but mine just sent me back here when I tried to join.
Yeah.
I don't know why it's closing the groups as well as soon as I'm trying to fiddle this. So apologies. It seems to be doing its own thing.
Technology.
Yeah, I'm sorry about that. Let's just quickly.
Oops.
Yeah. Sorry, you'll all go back into the same rooms, but I will think those who are struggling.
I was sent back here, but I don't know why.
Yeah. Sorry, if you are struggling, just go into the room and then and come back out.
Yeah, we are now in the main room.
Move, because I can't seem to. So rather you are in. Right. Let me perhaps just find out who wants to move to which room, because Cynthia and Alice in the right room. Daniel and Edmund Lee. All right. And then Francoise and Lana. Okay. And then I'll just rename the group, which is by the Spanish, Portuguese, just ignore it. You want to go into the French group, Anna?
We have been brought to the main room again.
Okay. If you're still stuck here.
I'm still in the main room, Cynthia. I think I was in group 3.
You're in group 3.
I was in Edmond's group, but I got sent back
Prof.
to the main.
It's,
I don't know.
it's happening to me as well.
All right.
Yeah, same here.
Let me take one at a time, if you don't mind. Sorry about this. Cynthia, which group would you like to go move to?
Any.
Cynthia, you are in the right group. It's group 3. Just click on join.
3.
Yes, that's your group.
Which group is POSA?
Serge, you are in the French group. Should be where you go. Francoise and Lena.
Yes,
join.
Shabi,
Yes.
I think there's an issue whereby participants are brought out of their groups into this main forum. It's happened to me twice, so now I think a couple of people have said the same.
Actually, somehow the technology is kicking out. So
I see.
So just go with it now, and I'm going to try and not touch too much because I think somehow there's something I'm clicking that's making you break out of the group and get back out. So apologies for all this.
Okay.
I think the technology is messing with me. So
That's all right.
just go with it for now. Somehow I'm not touching things, and yet it's kicking you all out of the room. So I think I must just be careful. I'll make group 5 the French group for people I think French speaking, and the other group Portuguese. That's an English group, so don't worry about it. Okay.
Shabir, do you mind putting me into group 1?
Is it Nikki?
Yep.
Let me just find where group you are in group 1, Nikki.
But I can't find the way to
joining.
access.
You're not finding it.
No.
It's actually somewhere. I have to move you around, and let's see if I can trigger it to give you a. I'm giving you a C2, but let me just see.
Prof, which group is POSA?
Also, give me a second, Nikki. You want to go into group 1, Nikki?
Okay, any group is fine.
Give me a second. Nikki, you're in. All right.
Promise was also kicked out. I don't know which group is Promise.
Purpose,
I'm still in the main group.
Yeah, Sankir is there, but Paul, so who's speaking? If you don't mind, just put up your hand.
English, take me to the English speaking group.
Right, I'm gonna have to jiggle you around. For some reason, this, you're not gonna go into the same group we previously put you in. So please bear with me. Just please watch for the prompt that you get and use it, please. If you get a prompt, please join that group. Otherwise, we're going to be constantly.
Which group?
Whatever comes up, please join the group. Otherwise, we're going to have troubles for you to get back to the same group. So just bear with me and join the group that you are getting a prompt now to say join the group. Right? So please, if you can just join the group that comes up. Otherwise, I'm risking kicking up, making a problem for all the groups if I'm playing around too much. The technology is somehow messing with us. So if you're still in the group, please just let me know. You should get something. So Paul, I'm gonna. I think those who are still here, I'm sending you links, but you're not joining. So unless you want to unmute and let me know, I won't be able to help you.
No link yet.
Sorry, who is this? Sankira, I've left you in the main group. This is actually a big problem. Are you able to manage the breakout room?
I should assign.
Abdulrahim, I've tried several times to get you into group. Somehow it's not working, but you see there's a note that'll come up, say join a room. You need to click to join it. If you miss it, if you're playing around on your computer, you'll miss it quite easily. So all of you, I'm actually sending you 2 groups, but if you don't click on it, it will disappear and you'll actually be confused and still be outside here in the main group. I'm going to try to get you to join, but I don't want to be persisting. So if you're still in the group, please tell me, yes, I want to be moved, and which group you prefer. You can all unmute yourselves. So, Kiri, do you prefer joining a group or are you okay looking out for you? You can unmute. I think you can add people to groups, isn't it?
Yes, I'm adding them.
Good, good. If you can just handle that because I
Okay.
think my colleagues on this other meeting are getting very annoyed.
I'm adding them.
Good. Keep it going.
All right.
Why? Hey, Tommy. They want us at my hospital. Determine of it. Tommy, dear, yeah. Tommy, I'm at my area. Say there's a traffic. Elsie. Elsie. Elsie.
Thank you. It might be useful to send a message saying saying that there's 30 minutes when we get to the hour. And you can, using the broadcast on the breakout room.
30 minutes left.
Yeah, no, I think give them a few more till about 3 o'clock. I don't know what your time is locally, but when you get to the hour, just send them.
5 minutes to 3 o'clock.
Yeah.
In your time.
Yeah, you can just at 3 o'clock just say, give people a reminder of the time. So every 15 minutes you can do it till the end, and then at least that.
Should we give them extra time because of the technical issues?
Yeah, no, it's fine. It's perhaps early now, but just to remind people of the time. Sometimes they don't keep track of time.
So, but right now I have 5 minutes to 3 o'clock. So should I say 5 o'clock?
At 3 o'clock, you can basically just send a message, half an hour left.
Okay.
Yeah, just then in 15 minutes, you can say 15 minutes left. Maybe then at 5 minutes, just so that people manage their discussion in that broadcast.
I want to know, when should we get back to the main group? Because it's
at 3:30.
3:30, okay.
Yeah, that's the end, 3:30. So you can just send some regular.
Okay.
All right, thank you.
All right.
Participating.
Yeah. Hmm?
I didn't say it's 1 hour.
What you talking?
2 hours.
You said 2 hours.
1 to 2 hours. You should have asked him what exactly it is.
I thought you said you don't want to waste your
Excuse me, thank you.
My mother, the money.
Hello.
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 Can you please allow me to join room 6? I've joined it with another device because I had connection problems with this one.
Is it French or Portuguese?
It's English, Spanish. Port 6,
Spanish.
Eleta.
6. And let's okay. This is Portuguese and Spanish, right? I think I remember maybe.
Saha's coming. Hello, Evans. Evans. Edmond. Edmond. Anna. Anna.
1, 2, 3. I see. Yeah, but she may see me manage it Zoom meeting. Technical officer. Technical officer. Technical officer. I'm on for so what I'm going to say you move. I'll query. Or no, mammy. Idea very different. Saya sendiri. Antara gue. Oh. Oh kok. Masih
Hello, are we back to the main session?
A minute.
Yes, we are.
Yeah, we
Yes,
are
we're
back.
in the main room now.
Hello. I think we'll just wait for the rest of the people to come.
Okay, while we're waiting, I feel it was a very, very, very interesting breakout room. My God, now I feel the 1 hour wasn't. Initially, I thought the 1 hour was much when we're sharing the time for the breakout rooms and the preparation for. I was like, I wanted to say 1 hour was much, but now it's not enough. It's not.
No, it was a pleasure, and I think it's I think we have so much to learn from each other, and the more we can actually have these opportunities, I think the better for everyone, right? So I think all breakout rooms will close in 50 seconds. So we'll just wait a little bit for them.
I think we're already here.
Is it? Okay. 35 people. Oh yeah, you're right. Okay, thank you so much. Thanks everyone. I hope that you have enjoyed the breakout rooms. I know that there were some hiccups.
Anna, can I suggest you wait a few seconds? I think people are still in the breakout rooms.
You think
we
so?
wait
Yeah.
about 30 seconds, then they'll all be here.
Yeah, okay, we can wait a little bit. I'm just, checking.
I think there's just one person who's not joined.
Yes.
Everyone else in their main room.
There seems to be only one person. Yeah, I think that's fine now. Okay, so thank you so much. It was very, very interesting. So I think we'll just do a little bit of a wrap up now. And the idea would be, I would maybe invite the facilitators of each one of the focus groups to share with us your learnings. Of course, you don't need to be extensive, but just share the main things that as a group you are going to take out of this breakout room. So anyone wants to start? Raquel, shall I bring you to the spotlight?
Okay, thank you so much. It was really, really interesting to be part of the breakout rooms. I think we had the chance to learn a lot from each other, so we'll try to make a brief summary, and then I will send you the main summary to the group so you can have access to it. So regarding to the first question, what are the digital health technologies that have been used in primary healthcare? We mentioned several of them: telemedicine applications, oral health scanner. There's a huge market that is put into place, but unfortunately, and this leads us to the next question. There are huge benefits using, for example, the skills that population already have using social media to teach them to use the digital health solutions. But even though there's potential opportunities and a lot of strengths, there's also a lot of challenges, because if there's not enough access, if there is not a regulation or guidelines, a framework that supports this implementation of digital health solutions, that could increase the problems of using it, and also the potential increase of inequalities. So we also went through the offline challenges, the access to internet connectivity, or the problem to power computers. So we went to the challenges, even though we were really agree on all the potential benefits that digital health solutions can bring into place. So just going back to the last question, how could support digital health technologies universal health coverage in Africa? Potentially it could help to bring access to everybody, but only if these previous challenges are taken care of. So if there's regulation and security is assured, if the equal access is also assured, we can bring up in these newer technologies. We also discuss about political leaders or other stakeholders that can help us to use digital technologies in the future, and also about our harmonizations. So at least to prioritize open source platforms that can be interoperable and make sure that integrate any type of technologies. So that's in a nutshell what we have been discussing. Thank you so much.
That's very comprehensive, Raquel, and again, touching a lot of different aspects on quality and safety quality. So that's very comprehensive. Thank you so much. Anyone else wants to share the results from their group?
If I can suggest to those who have, before you share, is others who have been hosts before, co-hosts, I've actually taken them off, so now you should be getting it. The ability to fill in that. I'm not sure whether it's allowing this to.
For the poll, yeah, it's working now, Sabir, because I can do it now. Yes,
yeah,
thank you.
Those who are still left, anybody else, I think just please fill it in, because it's quite important, I think, in this process to get a feel of the people and the diversity. I think just seeing that we've got Southern Africa, Eastern Africa, Western Africa, and Central Africa represented here is itself amazing, and there's a mix of nurse, clinician, doctor, other health professionals. I think that just is super, with a huge age group difference and male, female. And I think even language groupings, we've got, Spanish, Portuguese, French. So I think the fact that we've got different constructs coming through in the conversation, I hope that, the participants or the facilitators manage to record all meetings, because I think that people have been able to. So I think that'll really be important, and we'll try and capture all that data. Without that, we'd be very challenged with just notes. So I'm sure that you'll take up the question of notes. Everybody should have written up their notes, and I think they need some detailed notes. So please, if you can just put that forward. Thanks, Anna, sorry.
No worries. And I certainly agree. I think it was so rich that, there's a lot of knowledge to extract out of here. So maybe can I invite you, Eleleta, to share the results of your group? Would you mind?
Yeah, no worries. Thank you, Anna. So I'll just highlight some of the most standout topics that we've discussed in order to avoid repetition, and also in the interest of time. So for the first question, participants from Zimbabwe and Mozambique pointed out that there is a central repository system for central data collection to ensure centralized continuity of care. And that's how digital technologies are being used in their primary healthcare settings, which also brings us to the second question. One of the primary benefits of digital health is to ensure a centralized delivery system. So there is a continuity of long-term care, as well as continued communication between healthcare workers, so that patients are able to get their diagnosis and all their lab results in real time, and they're able to go ahead into treatment, which also finds a wraparound around appointment waiting time. That being said, the major challenge that we were able to identify is the issue of electricity and connectivity issues, particularly which is a major concern in rural Africa. Another challenge would be digital literacy, also in rural Africa. So in the presence of digital divide, it would be quite a challenge to ensure primary healthcare access, especially in rural Africa. The last question, how can digital health support universal health coverage? One of the most important points that was raised is that it would bring in data for some of the neglected issues that primary healthcare is usually not able to, conventional primary healthcare is usually not able to answer. That is data on non-communicable diseases, data on dental care, data on mental health. This would be able to be collected through digital health in the context of universal healthcare.
Thank you so much, Charlotte. And again, I think that's also a recurrent theme around digital literacy, digital divide, and how actually we work together to make sure that no one is left behind. Because of course, we all hope that this is going to improve healthcare for a few people, but what we don't want is actually to separate, to entrench these inequities that are already there. So that's a very important point. And thank you so much for sharing the results of the group, and of course to the whole group. Anyone else wants to share their results? So may I maybe invite, sorry, I don't want to put people in the spotlight, but maybe, may I invite Lana maybe?
Yes, sure. I think a lot of the discussion points that we discussed in group 5, I think, have already been touched upon. I think in terms of the first question on which digital health technologies are currently in use, I think one of the important points that came out of the discussion was that there isn't necessarily a single general tool being kind of used on a kind of across multiple settings or countries. So there's a lot of different tools that are being used, and some of them are things as simple as using WhatsApp to reach patients, and so yes, very simple kind of social media tools, but also the development of many apps in recent years, with more and more students and young professionals in this health sector working on tools to reach more patients and to follow them within their communities. In terms of the benefits and challenges, a lot of what's already been mentioned. In terms of benefits, obviously being able to identify people within the community and keep in touch with them, and make sure that they are informed on when they need to follow up or have follow-up appointments or conversations with the healthcare professionals. In the pandemic setting, which we're all currently in, the ability to have that contact with patients when social distancing is enforced. So being able to still see the patients or speak to them using the digital tools. And also continuity of care is one of the potential big benefits. So being able to share patient records across different providers or different healthcare sectors is another one of the opportunities. Challenges, as been mentioned, so access being the main one. So internet access, especially when it comes to some more rural communities, access to the devices that the patients need to make use of these technologies, and then also more kind of future-centric challenges like implementing the necessary legal frameworks, especially around data security and confidentiality, and also the need to ensure that all the stakeholders buy into the idea of these new digital health tools in order to push them and to implement them effectively. So yeah, those are some of the key points.
Thank you, Lana. And I think you touch, actually, we can already see the teams coming together. And there's this point around continuity of care that Alelete also mentioned before. There's a concept about digital divide. And that's also very interesting to hear that a lot of us actually bring this point about involving all the different stakeholders as part of the conversation, because more and more we know that it is not going to work if we don't do that, right? So that's very interesting. So I will maybe ask Alice to share the results of your group, Alice.
Yes, I was really happy to collect information from Nairobi, from Zambia, Zimbabwe, Cameroon, Kenya. So thank you very much for sharing your experience with me. So I will only mention the thing that weren't mentioned before. So regarding the benefits, I think that some of our participants mentioned also the possibility of having a tele-supervision. That means the possibility to supervise colleagues across rural areas, urban areas, and also different countries. That was a really interesting possibilities. Then a participant pointed out a very interesting point. So the possibility to shift with digital technologies the perspective from the disease perspective to the health perspective, promoting the preventive care. And obviously the increasing also of digital health literacy across the countries. Regarding the challenges, we already mentioned the digital divide and other themes that emerged also in the European part of the project. But what really interests me was also the one challenge, that was the lack of trust regarding the use of data. So there is also a theme about the building of the trust regarding the use and the this data, the data that we collect through digital technologies, and how we exchange this data. And also the lack of one barrier was the lack of intentionality to design the digital technologies for the remote areas. So there should be a research about how to improve the design of these technologies. I think that these are the main points. Thank you very much.
Thank you so much, Alice. And again, it's really important because I think you bring something that we haven't discussed so far, the opportunity around training. So a lot of this is actually about, we always think about direct delivery of care, about direct interactions with patients, but there's certainly a lot of potential on training healthcare providers and healthcare staff in general, and maybe training patients as well, and making them more more empowered and support them to self-manage their conditions. So that's a very relevant point, I think. So I might now ask Nikki, would you be happy to share the results of your group, Nikki?
Yeah, sure, of course. So I co-facilitated group 1 with Mercy, and we got some conclusions that I'll share now. So we spoke mostly about Cameroon, South Africa, and Sierra Leone. And across those countries, we could see that digital technologies were used across different levels and different parts of the health system. So at the very individual primary healthcare level, telephone and SMS were used for patient appointments and reminding patients about when they were due to see healthcare professionals. It was also used for DHIS data collection, and that was facilitated through the use of apps feeding into healthcare data collection at the regional and national levels. And then it was also used for treatment and diagnostics, so around lab work that was all computer generated and actually faster for primary healthcare staff to access lab results online rather than through a print or paper method. So some of the benefits that our group highlighted were the ability to make quick decisions at the district or national level based on that data collection that was done through DHS, a lot of efficiency at the healthcare organizational level, as well as the ability to identify patient need more quickly. And so we spoke about this in the context of HIV, where patients may have dropped out of care. Digital technologies facilitated a much faster way to re-engage with patients in that context. Now, some of the challenges are, again, what have been mentioned by other teams, but connectivity and systems and structural challenges were mentioned again here. An interesting discussion point we had was around staff training and how sometimes there is the ability to train staff on the use of digital technologies, but if things like staff turnover are very fast and staff are changing all the time, it can be difficult to keep that knowledge current and to make sure that staff involved with this kind of work are using technologies to the best effect. And finally, the discussion on challenges centered around patient education, again, reflecting on what we previously heard from Alice, that patients really could benefit from being engaged with work into digital technologies and their use in healthcare, particularly where a lack of education and awareness may limit them from receiving the best possible care. And we close the session by having just a quick discussion on the impact of COVID-19 and how that has impacted in our participants' experiences, and they felt very much that patients were more supportive of using digital technologies to facilitate their healthcare, but still felt that there were some cases where they did need the personal touch and to be able to go into a clinic and see a doctor or a healthcare professional face-to-face. And the final point was just the importance of digital technologies in getting us towards achieving universal health coverage, particularly coverage in rural regions and to underserved populations.
Thank you, Nikki. That's very comprehensive, and it's nice. Well, this reflection about the role of COVID and how it actually supported this digital transformation is quite interesting as well, as something that we have seen in other countries. And of course, I think it was a global effect. So it's also interesting to understand how do legal regulations and everything that was discussed here before, how do the frameworks that support the delivery of this kind of care will change accordingly or not. So that's potentially an opportunity for the future as well. So we have a few questions here. I might just pick one of them here. So there's a question from Adubna that asks about the role of modernizing already existing social institutions to make them digitized, I think. Do you want to expand a little bit on that one? Would you like to expand on this one, Adunya? I'm not sure if you're still here. Maybe not. I don't think it's
You
here.
can unmute yourself, Adunya. I can.
Okay, thank you for giving me this chance.
That's fine.
I was thinking to propose some idea like here in Ethiopia. I don't know if you know that there are some social institutions, already existing social institutions like ECOB or EDDER. There are institutions like the people collect themselves into some groups and they collect their money into some organized account, and they pay for common goods, like if you think that for funeral purpose. So can we use them, those social institutions, and modernizing them may help us to fulfill the universal health coverage, so that the people do not suffer from financial hardship to pay for their health purpose.
Perhaps I can respond to that, Anna.
Yes, please.
I don't know if it was clear or not.
Yeah, no, it's clear. I think it's something in South Africa that we call stokvels. In other words, a community or a group comes together, puts money together. If someone has a funeral, then they give it to the funeral or to health needs, etc., like you put it there, you know, wedding, etc. It's a common concept, I think, in Africa. If I may say that it's probably everywhere in Africa, because it's there are very few social institutions to provide community support, and it's one very important one. I think that it's in fact become the basis for Rwanda to begin its path towards universal coverage. And I think that started off as community-based health insurance, with community groups actually collecting money and then funding partly the facility for that community. And there's a lot of value in the community governance in just being community-based. One of the challenges with that, and I think that information and this process still will apply, but one needs to be guarded about it. And I think it starts with that kind of thing. And Gugu's still, I think, on the call. There are possibilities in time for us to have a framework for that to happen in Africa. I think it will take some work. But one of the challenges with community-based health insurance, and it was there in Rwanda, is that it becomes unequal pools. It's fragmented pools of funding. And I think that government needs to explore that as a begin. But what happened in Rwanda is that they found rich people having more money, poor people having less. It still helps, but it's not equity across the country. So eventually one needs to take that and lift it into a national space where government, in fact, doesn't need to go through getting to collect money from individuals, but actually tax people a little extra, hopefully more progressively, and then pool it. And that's kind of the path as well in African governments, is they're not appreciating the value of or the cost of out-of-pocket expenditure. and that, yes, we do want to have progressive taxation for corporates and other sources of income in a country, but governments are very afraid that they will, business will run away. But it needs to be a mix, and they can actually find a low base and start from there. I think more than the collection of money, the bigger challenge in Africa is the systems that are available. And I think that building up decentralized units of care with strong electronic health records can actually be a very important way to bring information together to improve the quality of care. So I think your suggestion is a very good one. Just we need to think how exactly it pans out.
Can I also?
Yeah, of course.
Sorry, I'm also from Ethiopia, so I can maybe answer this for Adunya. Adunya, I'm not sure if you know this, but this concept has already been digitized in Ethiopia with the name Ukub. It's already a mobile app, and it's already in function right now. They're actually not doing anything in health right now, but I have heard that they have been having bilateral conversations with the Ministry of Health, as well as another digital health platform called the Erasmus Medical Technologies. So this is probably going to be implemented this year or next year latest.
Thank you, Loleta. There's also a question from Bernadette. I think there's a raised hand there. Would you like to ask something, Bernadette?
Yes, no, I just wanted to add something regarding the aspect of community-based financing, because if we moving forward, it is important to manage the situation of the out-of-pocket payments. And considering I'm from Cameroon, and we have in most of the English-speaking area, we have the village development organizations. Mostly they cater to bring clean water, they build schools, and I think it makes sense to advocate for them to expand their services within the aspect of health, because if you have a community-based, let me say, a rural nurse that is being sponsored by the community, the areas where the people have all those literacy biases, technology biases, the community can then take care, and in combination to the remittances and funding from the diaspora, healthcare financing can actually be an innovative area, and it will also reduce the cost for those communities. Yeah, that was just my input. Thanks.
Thank you, Bernadette. And again, it's really nice to have such a diverse group, because for us, these are completely, it's always good to learn about different ways that societies find to tackle common challenges. So that's really interesting for us to hear as well. So I think we'll probably just end up now with the feedback from the last group. I know the results already because I was there. I think most of the things were very, very similar, but there was something that I really enjoyed listening, was a quote from one of our participants that said that digital transformation needs to be approached from a humble perspective. Would you like to share a little bit more about that, Edmund?
Yeah, sure. I'm happy to share some of the pertinent findings we had from group 4. And apologies if I butchered any of the quotes. So starting with the first question, in terms of the digital health technologies that are available and in use, the participants described that mostly it's been used in terms of kind of allowing for easier access to health records, and also in terms of helping with insurance financing and all that. Insurance claims, sorry. And often this is reliant on telephone technologies rather than digital computers per se. But often it's done so in a very often informal, not often recorded, documented kind of fashion. And it's predominantly still found in more hospitals rather than in the community settings. In terms of benefits, for healthcare staff, positive benefits of using digital technologies, it's improved capacity, improvements in knowledge, and access to, for example, specialists to consult with. And in terms of from the patient's perspective, it's attributed to improving patient satisfaction, accessibility, and financial transparency. And in terms of the benefits, examples that the participants kind of gave were one of them is reducing times it takes to attend to patients in terms of, for example, reducing wait times resulting from having to look up records in a paper format in the past. Currently, it actually helps a lot with the COVID-19 vaccinations as well, where it's easier to document details and also using something like a COVID card to scan and look up information very quickly. And then again, the last one is it's related to national health insurance scheme. So it's easy to pull up a patient's insurance details, etc. And then for the final question, which is looking at some of the challenges, the participants identified that, well, there's a quote that really summarizes it all. Technology is not an end, but it kind of is a means to an end. And it's difficult to speak of digital health when you haven't addressed the human resources in the countries. And some of these issues that are mentioned included poor human resources and staffing. There's a lack of high quality and enough quantity of staff that are present who are properly trained, supervised, and motivated. Especially there's a lack of tertiary trained staff. And pertaining specifically to digital technologies, there's a lack of knowledge to maintain the digital technologies that are being implemented. And there's a lack of infrastructure that accompany to support digital technologies, such as something that we take for granted often is, for example, like reliable, affordable internet access. While a lot of patients may have one or multiple mobile phones, that's not the issue. It's the connecting internet network that is often not reliable or not affordable for a lot of the population. And often healthcare is something that's not, it's poorly financed, and it's not a priority for a lot of politicians and leadership. So there's a lot of, from the public, there's a bit of hesitance towards, is it appropriate for us to be focusing just on digital technologies when we have other pressing issues surrounding their use as well? And we do need to address these issues. Otherwise, one of the quotes I was given is, if we just focus on digital technologies, the tools themselves will become health for the rich, and it will exclude a lot of people who are could potentially benefit from their use as well.
Thank you so much, Edmund. I think it's a really nice way to finish it. And I think we talk a lot about the potential of technology, but it's a really strong final message. It's not about technology on its own, it's about the people that technology is serving and how we make that in a sustainable way. And I really like this approach to look at all of these from a humble perspective, trying to recognize the characteristics of the settings, what works, rather than trying to push things that might not work in a given setting. So from my side, it has been a pleasure. Thank you so much for these discussions. And I hope you feel the same. I think we have learned so much from each other. I'll leave my contacts here in case you want to reach out or know more about this work or other opportunities to work. We are really keen to collaborate. And I'll probably just now hand over to Françoise, which will do the final closing remarks. Would that sound fine, Shabir? Thank you so much.
Françoise, if you can give some closing remarks, hope you can unmute yourself.
Hi, everyone. It's exciting again, as if we should not leave, but we have to, it's time, it's top of the time. I want to thank you all, both the participants and our presenters. It was quite an interesting topic today on the digital solutions, digital health, digital skills. We've all seen the gaps, the challenges, the strengths. I think most of us in Africa are still trying to work on what can work in our system, what can best fit, how we can bring the government authorities into this. And this workshop today has revived us again that we should keep up what we are doing, and it's also a good forum to meet and hear what others are doing so that we can also learn from you people and see how we also apply it in our context. I want to thank you all for being part of this meeting this afternoon. We look forward to seeing you again next time and to continue the sharing. Thank you very much.
Bye-bye, everyone. Enjoy. We'll be in touch.
Thank you. Thank you, Shabir. Thank you.
Bye-bye, everyone.
Bye. Thank you so much.
Bye. Thank you.